Sue Sinclair, just so we can note those.
Afternoon, Russell. I think we good to the live stream's good. If
okay.
We should be good to go.
Okay, thanks, Richard. Okay, just seeing who's not on the call at the moment. So okay, ladies and gentlemen, well, welcome to this, the June Worcestershire Acute Public Board. And we're being live streamed as normal. Just before we get going with the formal business, I just want to say a couple of words. First of all, congratulations to Sarah Shingler, our Chief Nurse Officer, who has been promoted, secured to become the new Managing Director down at Wye Valley. Sarah, you'll be missed by colleagues at Worcestershire, but you're only down the road, and I know you'll be working very closely with us to ensure the joint success of Hereford and Worcestershire and all of the citizens that we look after. But really pleased for you, Sarah, and congratulations. And secondly, this is the last board for Joe Newton, who's been with us, I think, since 2020. But Joe and I have known each other for a lot longer than that, from the old PCT days and when I was chairman at the Robert Jones and Agnes Hunt. Joe, I think your plans are at the moment just to retire. So we wish you well, and you leave with enormous thanks. This morning in the board workshop, we discussed the Green Plan, which Joe has been leading, and you've made an enormous contribution over the years, Joe. So you leave with our love and best wishes and care for the future, and I know you'll always be a friend of all of us and Worcestershire Acute. So without further ado, we will get going. First of all, we have apologies from Sue Sinclair, and I don't think we've got any other apologies, have we, Joe or Gwenny? So have we any new declarations of interest? Please raise a digital hand if you have any new declarations of interest. Okay, can't see a digital hand raised. So the minutes of the last board meeting of Worcestershire Acute held on the 31st of March. If there are any points of accuracy you'd like to address, could you raise a digital hand for me, please? Can't see any digital hands raised, so I'll take those as accurate. So we'll go to page 6 on the board pack for the actions arising. And the first was an update on telephony to be provided to Tony. And I think that's been done, Tony. Can you just give me the thumbs up? Super, thank you. And the second was to consider how to capture benefits realisation of workforce investments at the Financial Recovery Board. Neil, to be honest, I can't quite remember what this referred to. Educate me if you can. Neil,
sorry, Russ, I was trying to get off mute there.
Hesitation from you as well, Neil. Is that correct?
It is, yes.
Okay, no worries. We'll need to make sure we capture the action points a wee bit better going forwards. But I think generally for members of the public, we do, given we're in a situation of financial recovery, have a board subcommittee, which is the Financial Recovery Board, which meets every month. works in rhythm with the financial and performance executive meetings that we have to try and ensure that we can turn around the financial deficit of Worcestershire Acute as quickly as possible. So there are a whole series of things that go on in that. Any of the matters arising that you feel I've missed? Could you raise a digital hand for me, please? Okay, we'll therefore move on to the full board meeting of the 7th of May. And again, for members of the public watching this live stream in the future, I really would encourage you to come to those meetings. They're a different type of board, but with a whole variety of interesting perspectives as we compare each trust on different metrics. The next one is at the beginning of August, so you're warmly invited. But in terms of the accuracy of those minutes, if you had any points on accuracy, could you raise a digital hand for me, please? Again, can't see any digital hands raised, and the action points arising will be taken account of in that meeting. So without further ado, we'll go to our Acting Chief Executive, Stephen Coleman. Stephen, over to you for your report, please.
Thanks, Chair. Yeah, a few things that I just want to draw out and probably set context for other bits that we're going to cover in the board. So we are aware, and there is a lot changing at the minute, certainly in terms of national and regional focus and plans. So the one that I've drawn out is around the changes to the ICB. Well, there was a document that came out around the model ICB that set what they were now going to be focusing on, and I've put that there as the core functions. So I think in particular the strategic purchasing, developing a long-term strategy and understanding the local context is very much where they're going. I think the impact for us in the trusts is that there will be much more probably direct performance relationship between ourselves and region rather than with the ICB kind of in the middle of that. But also I think that's a chance for us to step up and to move into more spaces around the actual service models that we want to see, the provision around that. So I put that there. The other bits that I just wanted to draw out is there was obviously quite a significant cost reduction for the ICB that they've got to work through, but then that mirrors what we've got to do in the trust as well. So across the system, there is quite a lot that all partners and ourselves and the ICB are looking at in terms of how we actually, particularly in terms of corporate services and other services, how we operationalise that and reduce headcount. The other to draw out is confirmation of the proposed ICB cluster arrangement, in that Hereford and Worcestershire will cluster with Coventry and Warwickshire. And a fairly obvious one is that really works for us, given the footprint of the foundation group. It now mirrors, and it really gives us a chance to build on that. I've pulled out some of the ICB updates just to keep board sighted on those, so building a sustainable future and the joint forward plan. The one bit I would draw out with, particularly with the building sustainable future, I think with both organisations at Wye and Worcester, is the opportunity for us to look at the cost of service, the effective of service delivery across the two, and really try and ramp that up over the coming year. For those particular services where one or other are struggling, or where as a system we need to make some system changes as well. So we have some examples of those services, such as dermatology would be one. I've referenced the Tier 1 urgent and emergency care, so due to our performance both here and in the system, we've got our next Tier 1 meeting come up. As part of that, we've agreed 3 work streams that we will look on as a system, and I've documented them there. So more internally is the reviewing ED processes, and I'm sure we'll touch on that when we do the performance review. There's a particular piece of work about reducing community length of hospital length of stay, and we really need to kind of accelerate and get the benefits from a system-wide frailty model. So those work streams are in train, and we will keep board updated on that. In addition, Chris has been leading a 30, 60, 90-day improvement piece with our medicine division, and we're expecting that to come through with clear metrics as well. Moving on, there was an absolutely brilliant operational excellence conference which Jane from Wye Valley organised and had operational managers from across the foundation group. I've already seen in action actually that some of the presentations that were given, trust taking that back into their own, contact being made, and I think that will help not only drive the improvement but the productivity that we're trying to achieve over the year. And I think there's a challenge there for about how do we get clinicians in that space and doing that as well, because they can be real leaders in that change. And then I've pulled out some stuff from our great teams, and the one thing that I've always said in my time with the trust is, as difficult as things can be, you can always come across moments of brilliance, and this is one where mum and baby, and people may have seen it in the media, who were both on life support, were brought together for that skin-to-skin contact. So just the organisation and Justine, you'll be aware that the thought that goes into this with teams is just brilliant. So just wanted to really bring out that. Mention the improvement week that we had across the foundation group, which is kind of really bedding itself in now and gives people a chance to kind of network. And finally, we have a lot and some brilliant volunteers around the trust, and we've just done a brilliant volunteers week. Sarah and I went down to see them at the kick-off at Worcester Royal, but I put some details there, but we can't say thank you enough. Their impact across our services can't be underestimated. Happy to take any questions, Russell.
Well, that's great, Stephen. And just to add, before I invite any questions or perspectives on Stephen's report, before we dive into the detail, I want to have a big shout out to our A&D teams, both at the Worcester site and the Alex. We are really conscious as a board as to the extraordinary lengths you and your family and loved ones go to try and deliver the best possible care. Some really great progress being made over the Alex recently. Thank you for the team over there. And we know the demands being placed on the Worcester team. So thank you to Claire Bush and everyone else involved at Worcester. Any questions or perspectives to Stephen, or do you want to dive into the detail through the integrated performance report? I think we're going to go straight to the details, Stephen. So over to you for your summary, please.
Yeah, I'll be brief. I think the key bit that pulls through, and it's common, is the improvements that we need to make around urgent and emergency care flow in the hospitals, particularly around our unplanned admissions. So they drive such a lot of the indicators, not only around performance, but around quality and finance. And that comes through. It was a particularly difficult period that we had in April. Not all down to attendances, but we did have some days of quite significant attendance. Almost, it was at some points higher than we'd had in winter as well. So we had to manage that through. That was really what I was drawing out. We're still managing to hold our elective performance, and cancer is one that I know Chris will touch on as a real area of focus that we can't lose sight of that as well. But that's all I wanted to just say and highlight, and then let relevant execs drive into the detail.
Thank you very much. And we're all sort of okay-ish on the money as well so far. So quality and safety. Jules and Sarah, over to you.
Shall I start, Sarah? There you go. Thank you. So thank you, Chair. So mortality indices remain as expected in the range that we would like to see, but we're continuing to respond, monitoring. And
Jules, I apologise. There's quite a lot of feedback at your end. I'm not sure why, but we'll try again if everyone's on mute. Back with you, Jules.
Just hand over to Sarah, because I think it's actually my end. So and I'll come back.
Okay, Sarah, over to you.
Thank you, Chair. I'm going to take the quality part of the IPR as read. Chairman, we're going in the right direction. Complaint compliance is improving month on month as per the plan. We have a reduction in falls and a reduction in our hospital-acquired pressure ulcers, and also a reduction of our infections, bar that we've had one MRSA bacteremia reported on one of our inpatient wards last month. So I will stop there, and hopefully Jules is now sorted.
I don't know whether that's any better, Chair. It's I have company next door, which is quite loud, I think.
Okay, so we'll run through you, Jules, and hopefully we'll be able to cope. Back with you, Jules.
Thank you. So as I said, mortality indices continue to monitor and responding to any trends. So group will be aware it's about trends really in those, and we continue to watch those carefully through our learning from data framework. People will also be aware we've had a lot of focus on sepsis and fractured neck femurs over the last few months, if not possibly a bit longer. There's a lot of work still being done in that space to try and move those both forward. And we've got quite a significant number of changes going into our neck and femur pathway over this next month, including a new service. The orthogeriatric service has commenced, and some reconfiguration of trauma beds and a workforce review, all of which we're hoping will bring the changes we need to see in that space.
Super, thank you, George. Thank you for working your way through the background noise. Questions or perspectives to Sarah or Jules? Team? Dame Julie, as our Chair of Quality Assurance, how are you feeling about our quality and safety environment at the moment?
I've had quite a lot of detailed discussions with Sarah and her team and Jules recently, and actually, although there are still issues to address, the improvements we've seen in a lot of areas are really very good, and I would commend the teams for that. I mean, as Sarah's pointed out already, we're still having a bit of issue with infection control, but there's a lot of progress in a lot of areas, and I would particularly commend midwifery again for what's been going on in there. When I think how far we've come in recent years, there's a lot of really good progress. The teams are working extremely hard, and they're to be commended, both Sarah's and Jules.
Okay, thank you very much, Dame Julie. Any other questions to Sarah or Jules? Okay, so we will move on then to the engine room, so to speak, of the organisation. Chris, over to you for the operations performance update, please.
Thanks, Chair. I'll take the report as read. Just a few bits I'd just like to pull out and draw to the board's attention. So if I start with elective care, we've got less than 1,000 patients waiting over 52 weeks, which is still 1,000 more than we'd like. But in terms of it's broadly on track with what we said we would be around our annual plan. And actually, as a percentage of our waiting list, is about half what it was a year ago. We need to half it again in order to get back to where we said we would be from an annual planning point of view. But actually, in terms of those specialties, it's limited in terms of volume to a smaller number of specialties holding the bulk of that work. And those specialties have got specific plans in place to address some of those concerns and waiting times, along with working with our partners in Wye Valley for some of those mutual aid. But more work to do on an elective point of view to get where we really want to be. The particular challenge we do have around ophthalmology corneal grafts, because we're reliant on graft material being available from the NHS Blood and Transfusion Service. So that's to some extent out with our control, but we're looking for mitigation plans specifically around access to that material. From a cancer point of view, we're not making the progress I'd like us to be making in terms of recovering the position where we know that we need to from a patient's point of view. That said, we're broadly on track around where we said we would be around our annual planning commitments, but more work to do, particularly around the skin cancer pathway, where we're working with Wye Valley through the managed network and with our commissioners around what that service might look like going forward to make it more sustainable for the population of Worcestershire. The breast service has struggled in recent months, but they've got a trajectory to recover that by Q2 with some changes in the work they're going to be doing there. And neurology continues to be a challenge around performance targets, but particularly has been impacted by a number of peaks in demand given by high profile cases in the media. But actually there's lots of really good work the team are doing in terms of how they can mitigate that and expand the capacity within their current workforce in terms of productivity opportunities. And the skin cancer pathway in particular is looking to launch its teledermatology service in June or early July, which will help in terms of streamlining some of the patients coming in to that service. From a diagnostic point of view, I think just to draw board attention to the audiology and the percentage of patients waiting more than 6 weeks is of considerable concern. It hasn't really moved in a number of months. We did say last time that there was a trajectory to deliver that by August. In terms of recovery, that's almost solely around paediatric patients as a result of the work we had to do a couple of years, I think about a year ago, around looking at some of the challenges around the audiology waiting times and the hearing tests for paediatric patients. So there is a plan to recover by August, but conscious that we are in June, I am going to review that plan in detail with the team to make sure I've got the assurance we're actually going to meet the deadline. But clearly the big challenge for us as an organisation, the one thing around operational performance that is still keeping me awake at night, is our ability to improve the standards around the waiting times of patients, either in our emergency department or outside our emergency department, who are waiting on an ambulance or waiting in our department to access a bed. Still lots we need to do to get it right, both for our patients and for our colleagues working in that department. And as you said at the beginning, Chair, a massive thanks to the teams there for the work they are doing. So we're continuing both as an organisation and with our partners to have the UEC transformation and improvement programmes, a number of work streams we've discussed at length here previously, which I won't go into again. And as Stephen alluded to, the tier 1 support we're getting from NHS England and the emergency care intensive support team, who recently visited to look at our frailty pathway and looked at some of the elements from the community point of view around frailty. And they'll be revisiting again to look at some of it, our in-ED processes or in emergency department processes. And that's about how all of our specialties are working in the emergency department to make sure we're making best use of the things that are in our control. I think the other bit just to bring board's attention to is obviously there was recently the publication of the National Urgent Emergency Care Plan. So we are just assessing that plan against the things we've said we will do to make sure there's nothing else that we can add to our plan without distracting from things we're already trying to do. But lots in there around making the most of alternative opportunities, such as same-day emergency care and streaming pathways from the front door. The other bit then finally from me is, as we're in June, we are now starting our winter planning with teams in terms of what the winter plans will look like for this winter going forward from an organisational point of view about things we can control, but also the things we need to do with partners. And we continue to work with our partners around getting patients into the right care setting as quickly as possible, so where they don't need to be in an acute bed, but need to have their care somewhere else, how we can make sure they can access their care as quickly as possible. But challenges, as you can imagine, Chair and board in that space continue.
Thank you very much, Chris, and thank you for the broad sort of front line of activities you're having to work on. Questions and perspectives to Chris. Colin?
Chair, Chris, in the section on urgent and emergency care, you make reference to an increase in the number of trauma beds. I wondered if you could explain what the driver was for that and whether it's going to give us a cost pressure.
Certainly, Colin, thanks for the question. So what we've asked the surgical division to do is to assess how they're using their current bed base within the wards that are allocated to surgery. So there's no overall increase in beds for the organisation and therefore no overall increase in costs. But actually, what we have found is that there have been patients that could be better cared for in a way that has co-located them with other patients where we didn't have the existing number of beds we need for that right patient. So, for example, we've had patients from trauma point of view in a number of wards as outliers. The division have come up with a plan that will co-locate those within the current bed base. So actually we would expect a better pathway for those patients as part of that. And there's been a full quality impact assessment that's been signed off by Sarah and Jules from the Chief Nurse and Chief Medical Officer point of view.
But I think it's fair to say, Chris, isn't it, that we do have a massive length of stay challenge and opportunity. And to realise that and to ensure that our patients are discharged as quickly as possible after they're medically fit for discharge, we do need system partners' help on that, as well as addressing some of our own internal protocols. And if we get that length of stay down, it creates the opportunity for flow out of the ED. That's a fair summary, Chris?
Yeah, that's a fair summary, Chair.
Thank you. And Simon?
Exactly to the same question. The report refers to collaboration within the system being critical to resolving the challenges within the UEC. So that was what I was going to ask.
Yeah, Stephen, do you maybe want to give us a quick update on how we, and I know both of us are involved in it, but for the public's benefit, working with colleagues at the Partnership Trust on the issues where we need system partner input?
Yeah, so I'll break it down into a couple of categories. So the first is, as I mentioned in my report, trying to reduce the length of stay in community hospitals. That then would lead to greater, speedier and greater flow from the acute into those community beds. So people wouldn't be waiting with us for a protracted period. And the other is the actual, the other, and we've got a pilot going on at the minute. So the other one is how we actually access those pathways or support for patients who need it. So there's the actual movement out into having the capacity to move to, but there's also the transaction of how quickly we can do that. And there's a pilot going on with some of our wards and trying to see if we can speed that up. There's some particular programs we're working on as well. So we've got one that where we are looking at a particular cohort of patients, which is general medicine and frailty, about whether we can, what do they actually need in an acute hospital that they may be able to have in a community hospital. And Sarah's been leading that piece of work, and the length of stay improvements look quite significant for that group. The other is around our fractured neck of femur patients, again, moving them more speedily out. And then finally, we've been doing some work around stroke, so we're hopeful that we'll be in a position where the teams are working much closer together with the rehab facility that the Health and Care Trust work. And then there's some community ones. So we've got single point of access, and the other one, again, that Sarah's been leading is hospital at home. So we're trying to run a virtual ward, which I think the trust has been a bit slow on the uptake. I think it's been more led by community, but this is us leading it with our clinicians' oversight, so that'll be positive. So there's lots of positive things to go at. I think the challenge that we've got is how fast we can transact all of that so that we improve the experience. We can really drive UEC performance in particular, but also we do have that is what we've currently got is an inefficient way of doing it, and we're seeing that through unfunded capacity that we've got. So it's a key bit to our financial plan as well. So there's a lot to go at. It's the speed at which we can kind of get our hands on it, I think.
No, that's helpful, Stephen. And just to members of the public and our citizens, we do apologise for the delays that you experience when you come into our UEC on occasion. We are trying to do at pace a lot of change to get the level of service and turnarounds that we know you would want us to be able to achieve. But we are addressing issues that have been around for a long time. So it does take a little bit longer than we would hope, but I do apologise on behalf of the Trust where the delays have been unacceptable and the consequences have been profound. Colleagues, happy to move on? So Ali, over to you on the workforce people side, please.
Chair, I'll take the workforce slides as read, but just to pull out a few key points. As stated previously in public board meetings, one of the main concerns that we have from a workforce perspective is our over-reliance on agency staff to be able to run our services effectively. Our annual plan says we'll aim to spend no more than 4.7% of the annual pay bill on agency staff, and we're currently above that. We unfortunately do stand out as an outlier when we look at the national picture, and we know that what drives that is particularly our over-reliance on medical agency colleagues. So this is our main area of focus, and we've seen over the past 2 years, we have seen successive progress against this, but it's really not fast enough for what we need to be able to achieve that target. And to really be able to make sure that we've got a consistent substantive workforce that we rely on in that area. Now, what makes this particularly concerning is when we benchmark this against how we're doing with our vacancies and our turnover, and actually we perform really well in those areas. So we know we have a stable substantive workforce. So the drivers in terms of that additional capacity, additional pressure on UEC pathways that really contribute to that over-reliance on agency make this quite a difficult problem to resolve, but something we are focused on nonetheless. And we are working at the moment with divisions to try and understand what the key things are that we can do that will really take us to that next step in terms of that progress.
We know there are some difficult decisions to make there as well in terms of swapping out medical agency doctors that we have built relationships with and we have come to rely on for other solutions, but nonetheless that's an area we need to explore further, and we'll be using reporting through our financial recovery board to be able to go into more detail around what some of those plans look like and how that trajectory will get us to where we need to be over the next year. I wanted to highlight a very small decrease in sickness absence, but really stress that one of the key areas of concern has been around mental health sickness for our colleagues. And we know that, you know, a number of our colleagues are working in increasingly pressurised situations and also will have their own domestic reasons that will contribute to their mental ill health as well. Over the past 6 months, we have refreshed our staffing levels within our occupational health department to really make sure that internally we are looking after staff as well as we need to be, and that when people need to see occupational health physicians or nursing staff for that advice to be able to stay well at work, they can do so quickly. And they can do so when they need to. And I'm really pleased to say that performance in our occupational health area has got much better, so we can offer that support to colleagues. And the next step in that area is to provide some more mental health support as well, through employing a mental health nurse in that area, which hopefully will help us to address some of the challenges that we know our workforce are experiencing with their own stress and anxiety and being able to attend work. Other areas to highlight from the report, job planning remains an area of concern, but we are starting to see some progress. And I think over the next couple of months, we're likely to see our performance improve in that area. I know that Jules, our CMO, and colleagues are working hard in the background to review and consistency check a number of those job plans as they come through. And what we hope to do is move towards more of a job planning window as part of our annual operational plan that we can work towards to be able to make sure that we achieve the 95% compliance target that's set by us by NHS England for us to achieve as well. And the last thing really to highlight is around corporate and infrastructure headcount. So you'll see from the report there's been a very small reduction of about 11 whole-time equivalent in corporate areas. We know we have further to go there to be able to address some of the growth that we've seen from pre-pandemic times in corporate and infrastructure posts. One of the steps that we are taking from this week is that all corporate and admin and clerical roles will be advertised internally in the first place, and then internally within the Hereford and Worcestershire system for NHS colleagues, before we seek external applicants for posts. And that really is to try and make sure that we've optimised the opportunity for internal movement, and also that we've supported colleagues across the NHS in the system to reduce any compulsory redundancies that may come as a result of some of the changes within integrated care systems and some of the national changes as well. So hopefully that will support us to be able to make sure that certainly our headcount doesn't grow beyond what it needs to, but also to make sure that we are looking after NHS colleagues every step of the way and avoiding any unnecessary steps to redundancy or compulsory redundancy. Thank you.
Thank you, Ali. Any questions or perspectives to Ali? And Karen.
Thank you, Chair. Ali, I'm not sure if this is you or somebody else, actually. It's just about the non-clinical vacancies, and I'm particularly mindful of the comment in the paper that we've got 90.82 admin and estates vacancies, and I'm conscious, although it is a good few months ago now, when I did a walk around estates, there was some concern within the teams there about the level of vacancies that they were holding, and I'm interested in, do we know what proportion of that is estates, and if there continues to be a problem with the level of vacancies in estates and the impact on that of that?
So I'd need to come back to you probably offline with some of the detail behind that in terms of the proportion of estates vacancies. I guess for assurance, what I would highlight is we do have a vacancy control process. So when we do decide to hold vacancies at that recruitment stage, we have done a risk assessment for those vacancies that we do hold back as well, to make sure that we're not withholding anything that could impact on clinical service and clinical service delivery too. So there is that internal assurance and check process, but I wouldn't know the specific numbers right here and now for the estates. I can certainly get into that detail and come back to you on that.
If you can, Ali, that would be great. And Julie?
Thank you. I think you've partially just answered this. I was going to ask about, is there a vacancy review process when a post comes up about, is there a way of perhaps re-engineering or checking that that vacancy is still required? Or whether there's, you know, a technological solution or a way of doing it differently so that we can actually not need that post. But I think you've just answered that.
Yes, we do. As part of that weekly panel that we hold, when we do look at vacancies, we expect our divisions to have gone through a process of looking at how they can work things differently from a skill mix review, but also looking at whether we are missing potentially opportunities for apprenticeships and other development pathways as well, to enable us to make sure we've got the workforce for the future that we need to. So yeah, it's quite rigorous, that process.
Thank you, Ali. And finally, Simon.
For the question, a thank you or an acknowledgement of the huge progress that has been made on the job vacancies. I mean, it looks like a halving compared with this time last year, which is significant. I know in turnover as well has been a lot of progress despite the challenges that are still there. I just wonder if you or maybe Jules could go into a bit more detail about job planning and some of the challenges that you're facing there, you know, potential timelines of when we think we'll get to that 95%. Just a bit more information would be appreciated, please.
Yeah, Jules, do you want to come in on that one?
I will. I think it's much quieter now. I'm hoping is that background better, Chair?
It is. Thank you.
Committee member, board remember, there were quite a few strands to the job planning that we needed to kind of almost do in parallel or make sure we've got some of the sequencing right. So we've got some historical job plans and concerns that needed to be resolved. Ali's done a huge amount of work in that space, and we believe that we've made significant progress. And have got the majority of things kind of moving in that space, which is good news. The second element was in, making sure that we've got consistency being applied to our job plans, which is also in place. So we now have our job planning consistency panel, which we're running. Usually would be a kind of a monthly process, but we've been running that through the CMO group with our divisional directors on a weekly basis for the last 3 weeks now, and now ongoing, in order to get through the backlog of job plans that need to go through that review process. And we should then be at a position where we're kind of up to date, Simon, in terms of the current job plan. So that's managing the backlog and getting back on track. We can't move forward with new job plans until historical ones have been resolved. But that work is almost complete. So we're almost back to kind of current job planning process for most of our consultant and SAS body. So we're optimistic that over the next few months, we should really start to see that figure increasing. As Ali said, there'll always be a little bit of a lag just in the way we've currently got our job planning process in place, in that we don't have a consistent start of the year point for all of our doctors, but that will be the next step. Once we've got everything up to date, the next step will be to realign so that we have a window and can therefore do all of the job plans between December and the start of the new financial year to make sure they align with the annual plan, which links into the kind of productivity efficiency piece, and make sure that's all aligned. But we've got to kind of get everything in place first. But that's kind of the background of where we are. I hope that's enough detail. Happy to expand further outside of the meeting if required.
Thank you, Jules. Thank you, Simon. Just conscious of the time bit now, Stephen.
Yeah, just briefly to add to that as well. I think we're not under any illusion that one, the amount of work that Jules and team have undertaken to clear it, but the second is people may have a job plan, but the next bit for us is to make sure that's driving the productivity and the efficiency that we want. So, Sam, that's the next bit that we've really got to get into, and that's how it's applied, particularly, and I think it'll be a direction from NHSE around linking it to direct clinical contact and the work that goes on there, so we can draw a direct relationship between the job plan you've got and how we see that impact on patients seen and various other bits. So I just want to, that's a big bit of work, and we will be keeping board really close to that one.
Yeah, no, absolutely. And I just want to slightly build on that. and say, obviously, that Glenn Burley, the Foundation Group Chief Executive, has gone up to help the NHS on the financial reset. And the reason he and Jim Mackey have been put in place is because the situation in the future of the NHS is at a seminal point in its history at the moment. And we all need to pull together to ensure that the NHS actually fulfills what it was designed to fulfill for all of the citizens of the UK. But everyone who works in the NHS has their part to play. And I'd particularly emphasise those doctors who are on the medical agency roster. Come and work for us. Don't make the extra money working for an agency. Come and work for the NHS full time. The pension's good, and you'll be doing some good public service instead of, frankly, milking the NHS. And equally for nurses on the nurse agency, we haven't touched on that. But equally nurses, the pension for you is wonderful in the NHS. Don't work for a nurse agency. We're a flexible employer. Come and work for us. And like you've just alluded to, Stephen, for those colleagues who are going through the job planning exercise with Jules, and Jules, thank you for your leadership on this. Play fair with us and we'll play fair with you. We're all in this together. We want the NHS to thrive and be exactly the cause of celebration that we all want it to be, but we've all got our individual parts and collective parts to play. So with that sort of little speech out of the way, we'll move on to the money. We're 1 month in, Neil. We're running a few minutes behind, but we're doing sort of okay after 1 month, but we need to pay attention. Is that a fair summary?
That's a fair summary, Russell. Thank you very much. Thank you very much. So, board will be aware we've got a balanced plan for this year, but we're very reliant on that deficit support funding in order to achieve that 47.3 million. NHSE have brought in some new controls, which is around releasing that quarterly in advance, depending on how you're faring with your cost and productivity improvement plans in your overall financial position and controls. So, I'll come back to that when we speak about CPIP. So, yes, overall position at month one, Chair, is a 0.2 million adverse to plan. Doesn't appear as though that's a significant challenge for us. But when you look underneath, you look at the employee expenses, you can see that, as Chris has referenced, we've got some significant challenges around operational delivery that are starting to play out in the financial position. And indeed, the slippage on CPIP plans, and again, I suspect fully aligned to the fact that there's lots of focus on flow and operational issues as opposed to the challenge around CPIP. So we do absolutely need to get a grasp of that. Otherwise, this is going to quite quickly run away with us. So in terms of focus, we've got Michael Parr working with us as Financial Improvement Director, who's focused with the divisions on further developing the maturity of those CPIP plans. And I've asked the divisions at next week's Finance and Performance Executive to come back in terms of their run rate trajectories around what their mitigation plans are, because at this point in time, as I said, the run rate on employees' expenses particularly is of concern. From a capital perspective, we're ahead of the plan at this point, and board will be aware that we did sign off a plan that was in excess of the allocated resources. However, I'm not concerned at this point. We will incur slippage, and already we're seeing there's 1 or 2 plans that are starting to slip as we progress through the year. So I'm assuming that will by the time we get to the end of the financial year, we'll be there or thereabouts. And we'll certainly keep an eye on that on a month-on-month basis. Cash, from a cash perspective, healthy cash position at year end. Much of that is around payment of creditors, capital creditors, particularly given what we spent in the final month of last financial year. So we do need to keep an eye on cash, as I said, aligned to how the deficit support funding is being released. Just looking in the pack, you can see the profile of our CPIP trajectory there on slide 4 of the pack, I think it is, 44 in the pack. And you can see that we are down in terms of our maturity of schemes. We do still have some time to catch up. You'll see the graph to the right. Much of our CPIP is profiled in the latter half of the year. So we certainly got opportunity to get back in line with that, but we do need to progress forward at pace in that respect. That's all I really wanted to cover. Oh, sorry. The final thing, sorry, is that in terms of our plan for the year, it's built on an assumption of an assumed level of activity with our commissioners. We're still working through based on the revised payment system for 25-26, in a similar way to pretty much most organisations in the country, around landing that contract agreement with our commissioners, which we're hoping to do in the next week or two. We've had some commitment from our commissioners that they're not seeing any withdrawal of funds in that respect, but of course the devil in the detail is still to be worked through in that respect. Just wanted to get board sighted on that.
Thank you, Neil.
Any
Any questions or perspectives to Neil? Okay, sorry, Chris, and then we'll move on.
Thanks, Russell. Just a bit more assurance of board, really. So we have got a fortnightly CPIP or cost improvement programme meetings with our division. So we meet all the divisional leadership team every fortnight from an executive point of view to go through their schemes. The focus of those in the next round is very much about the agency reduction plans that we've alluded to, the productivity opportunities and the non-pay grip and control. I'm really conscious that we've talked about productivity quite a lot with the divisions, and there are some places where there are some real opportunities. So, for example, the surgical team are very much working up what they can do around increasing the number of joints that we treat on a list. There's a real opportunity. So we've seen some progress in that space, but there's more we can definitely go. And I think there's some learning from the definitely from Foundation Group partners at Swift in terms of that regard.
No, great. Thank you, Chris. Okay, keep us briefed on the numbers, Neil, for next month. And we'll move on then to the safe staffing report. First of all, midwifery, then nursing. How are you feeling about our staffing, Justine?
Actually, really positive in some respects. So you'll see within the report that we were safe on all shifts. Vacancies are down overall. For midwives, we're down to a 0 vacancy position now, which we're really very pleased about. You'll see still some challenges within our support group, but around sickness, turnover, and vacancy. However, we have got recruitment on track at the moment and expect to recruit to the vacancies in that group quite soon, with interview dates by the end of this month. So that should sort itself out quite quickly. You'll see no harm was reported there from our incidents, and our we were meeting the acuity much a higher percentage, which does reflect that decrease in the vacancies. Obviously, when the sickness rates reduce further, we do expect that acuity to be met at a greater level as well. Just to make the board aware, I have received the draft birth rate plus audit report. I'm just waiting for the finalised report now that we've applied professional judgment, and we'll be able to share that with you hopefully in the June staffing report. Nothing else to share with you at this time. Thank you.
Thank you, Justine. And we'll run into Sarah's update on nursing, and then we'll invite questions or perspectives. Sarah?
Thank you, Chair. So nursing, I'll take the report as read, but again, staffing on paediatrics, neonates and all adult inpatient areas were maintained at safe staffing levels. We did have our maximum boarding spaces and temporary escalation spaces open throughout this period. In addition to opening our medical same-day emergency care unit overnight to house our golden discharges to support flow to the easy overnight, and also our discharge lounges again to provide some additional flow. just on in the context of agency, we have just included the nursing workforce recap in the paper from 24 to 25. So just to demonstrate the progress that has been made over the last 12 months. So RM vacancy in April 24, we were looking at 178.5 posts. In March 25, we're looking at 66 vacant registered nurse posts, and this is because we are converting our agency posts into substantive posts as part of our divisional CPIP plans. And our turnover is also reducing from 9.49 in 2024 to 7.91. Healthcare support vacancies and turnover also on a positive trend, although as Justine reports, it remains a challenge for lots of other factors around pay and opportunities elsewhere outside of the NHS, which we continue to work through. And also is included is the comparative spend on the reduction in agency. So agency costs we have reduced by 38.6% over the last 12 months, and our off-framework usage has been reduced by 92%. And we only use off-framework now for paediatrics, and this is for support to our children with mental health crisis awaiting a tier 4 bed predominantly. So I'll stop there. So we have reduced our agency costs, but actually improved our staffing levels and maintained safe care.
Fantastic. Thank you, Sarah. Thank you, Justine. Any questions or perspectives from colleagues on these safe staffing reports? Well, that segues quite nicely then to the quality accounts for 24-25. Obviously a big report, been through our quality governance processes, but Sarah, anything you would particularly like to draw to our attention?
I think I'd hope that people at the board have actually seen more content in this year's quality count around learning and actually what we are doing where we maybe haven't met our ambition. The quality priorities have been reviewed and we have looked at outputs from our big quality conversation, our annual national inpatient survey, and also some of the priorities and this how the quality concerns that myself and Jules are leading on. So we are looking for approval from the board for those quality priorities to go into next year's account. We are just waiting for just one external feedback, and that is from HOSC. The team are continuing to have conversations, and you'll note that there are comments that have come in from Healthwatch, and we have now received responses, and they will be included for the final report. So as you say, Chairman, it's been through robust governance throughout the trust, from the Improving Safety Action Group, Trust Management Board, Quality Governance Committee, and then to the board. So I'm happy to take any questions.
Thank you, Sarah. Jules, is there anything you want to add?
Nothing to add, thank you, Chair.
Julie is the chair of the Quality Assurance Committee. Anything you'd like to add?
No, we went through it in great detail at the last meeting, and as Sarah said, there's still work to do, but it's a big improvement on the previous ones, and I think it shows really good progress.
So, any questions or perspectives from colleagues? Okay, thank you. Thanks for the immense amount of hard work that goes on behind the scenes. So if you're not happy to approve the quality accounts and the quality priorities for the year ahead, please raise a digital hand. Okay, duly approved. Thank you very much. So we'll move on then to the scheme of delegation and standing financial instructions, equally important in a different way. Neil, anything you'd particularly draw our attention to here?
Yeah, thanks, Chair. This is the annual review, and we've taken the opportunity just to further check across the foundation group that we're all aligned. We've added, in terms of the SFIs, some of the greater detail around some of the controls, for example, around contracts and water for governance and alignment with business cases, ATRs similarly. and we've looked at the sign-off thresholds and amended those. Again, nothing significant in that respect to highlight, Chair. To take any questions.
Okay, great, thank you. But we need to approve these as well, don't we, Neil?
We do.
Any questions or perspectives to Neil on these? Okay, if you're not happy to approve, could you please raise a digital hand for me? Duly approved. Thank you, Neil, and colleagues who have put in the work on those. So then on to the board committee reports. The first is the Equality Governance Committee from April. Julie, anything you particularly want to pull out on these?
I was actually on holiday for the April one, and Sue Sinclair chaired this one, but I think the minutes stand, and we've since had the May meeting, and those minutes will be coming next time. So I think they are pretty explicit as they are.
Okay, great. Any comments or perspectives on those minutes? Thank you, Julie. And then the Audit and Assurance Committee for May. Colin, anything you'd like to pull out on these?
Just one or two observations on the report, Chair. The draft head of internal audit is at the moment with us, and it's showing significant assurance, which I think is a positive achievement. There have been some reports where we didn't get to the best level we could have done in terms of our compliance and processes, but I think the internal auditors have taken a rounded view and given us what I would regard as a clean bill of health. So that's good. It's still in draft, so it could possibly change, but hopefully not. We also received the draft annual governance statement, which we went through in some detail, and we commend to the board for approval. And sorry, Chair, if I may, that the final point I wanted to make was that we received the draft financial statements for the trust. They're now in the tender care of the external auditors, but I'd never want to fail to commend the finance team for all the hard work they have to do to get these things produced, ready for audit in a very tight time frame.
Okay, great. Thank you, Colin, and thank you for those kind words, which I'm sure Neil will take back to everyone else. Any questions or perspectives to Colin? So the accounts don't come to us for approval. Do you want us to approve those now in draft form, Gwenny?
We've got a special board to approve the accounts when they come.
That's what I thought. Yeah, so we're not doing it today, are we? No. Okay, super. Thank you very much. Any other comments to Colin? Okay, then I think on to the People and Culture Committee, and Karen, over to you.
Thank you. With the timing of things, we've got ourselves a little bit out of sequencing just because of the scheduling. So you have in the pack the minutes from the 4th of February, which is seems and is an awful long time ago now. And there have been 2 meetings since then. We had a meeting on the 1st of April and also one last week. So just to quickly touch on the 1st of April meeting, we had an update from Rachel, the head of AHPs or associate director of AHPs. Well, yeah, is that right? And which was really, really good to see in terms of the work that is going on across the whole trust. And I'd put it out there. I think it might be a good board workshop. It's not for me to decide, but in terms of the impact that AHPs have, and particularly on flow, which is one of our biggest challenges, and they're doing some great work. I think that might be useful. The other area is we had the quarterly report on freedom to speak up. And we're seeing an increase in the number of concerns, which we are taking very positively because we've increased the training and made listen up and speak up mandatory for large portions of our staff. So hopefully that's a good thing in that they're understanding the process better. And further, in terms of good news, and that the number of anonymous concerns is reducing. So we're trying desperately to get away from the fact of the fear that people have about speaking up. It certainly comes up in every walkabout that Mel and I do in the organisation, but hopefully some of the training and the sharing that we're doing is starting to show a difference on that. As I say, there was also a meeting last week. I was away traipsing around Italy, which Colin very helpfully chaired for me. So I don't know if you want to pick anything up on that one, Colin, if that's okay, Chair.
One issue, please. It's already been touched on in quite some depth today, and that is the issue of medical agency reduction. So Ali referred to a number of the issues that we discussed at the committee last week, but the upshot of the discussion was that although an awful lot of hard work and commitment is going into this area, we still continue to turn over stones which reveal issues that require further work. And so the committee, whilst acknowledging the hard work, was not fully assured that we're at the point we need to be really on this difficult subject. So that we agreed would be escalated to board.
Okay, great. And therefore, any questions to Karen and Colin on what we've heard? If you're going to swan about anywhere, Karen, Italy's the place to swan about. We'll move on then to the PFI Expiry Committee. Really important issue for the Trust as we approach the last 5 years or so of our PFI contract. Tony, over to you.
Thanks, Chair. Just draw your attention to the 3 outcomes we've listed there. These are our objectives in the next quarter between June and September of this year. First is to firm up on a resourcing plan to make sure we're properly prepared for the exit arrangements. The second is a new strand for us, which is to manage the risk around the managed equipment service, which is run by Siemens, to make sure we've got a good understanding of what that may entail. And the last thing, and very important thing, is to get the jointly commissioned condition survey, which we need to run with our PFI partners, get that up and running in this quarter so that we can start to make progress in understanding what the condition of the estate is. But happy to take any questions, Chair.
Thank you, Tony. Really important subcommittee for the long term of the hospital. Questions and perspectives, Stephen?
Yeah, it's just a couple of things. I think it's one of those things that I will be picking up at Y as well, around how we join up best the two, because we're in a similar timeline and with resources being tight, I think that's important. And the other one, I just wanted to take the opportunity, Emma, who's our Director of Estates, we've re-established the PFI liaison committee with our the 3 partners of the PFI, and I have to say the last one we did is starting to show quite a marked change. In particular, 2 of the partners are performing really well, and the third, where we had some worries, I was more assured after that. We had a really senior presence and there was a really clear articulation of knowing the issue and getting on with it. So I kind of feel like we're moving in the right direction there. That still comes with a lot of work that Emma and her team have to do, but I just wanted to give that assurance to board because we have talked about that again previously. So just to link the 2 together.
Okay, super. Thank you, Stephen. Any other questions or perspectives? Okay, so the Trust seal, Gwenny?
This is just for information. It's an annual report, so I'm happy for it to be taken as read.
Okay, thank you. And on page 291, we've got all the times the Trust seal was used. Any questions on that? Then we've got the sort of revisiting of the terms of reference of the Quality Governance Committee. Sarah, anything do you really want to draw our attention to?
They've been reviewed, been through committee, so here for approval.
Okay, if you're not happy to approve, please raise a digital hand. Okay, duly approved. Then we're on to the Charles Hastings Education Centre update report. I'd just like to say to the trustees of the Charles Hastings Education Centre, our enormous thanks as a trust for the work that they have done, do, and I'm sure will continue to do on behalf of education with the Worcestershire Acute. Tony, what would you care to pull out of this?
Well, I think, Russell, the report's fairly self-explanatory. I'm happy to take any questions. Obviously, they got two big issues to deal with at the moment. One is the significant legacy they've received to enhance the museum facility, which they're looking at. And the second, which I think the Trust would have a particular interest in, is their intentions to massively expand the simulation facility and capacity in the building, which is a very big capital project, and hopefully they'll make some good progress in collaboration with the Trust in the next few months. Thanks.
That's super, thank you. Any questions to Tony on that? So our next meeting is on the 8th of July, but any other business, colleagues? Please raise your digital hand. Stephen.
Yeah, so I'm sure board members all watch Exec Live, which is a thing that we do internally with absolute regularity. But I just want to take the opportunity to update on car parking. And the reason for doing it here, as well as I know that members of the public and the local population are interested in it as well. So to give a quick update, we have got agreement with the local authority, and I really want to place on record my thanks to them around the use of car park 1 at County Hall, which we will be taking up from the 1st of August. That's really positive news for the Worcester Royal site on 2 fronts. One is the increase in car parking, but the other is that it has a separate access and egress onto the site. So the issues that we get, as well as the car parking, is actually more probably the gridlock that can happen at particular points in the day on this site. I've mentioned Emma before. Emma is doing an inordinate amount of work around this, and we have potential options as well that we're exploring for Kidderminster, which again I think will be a real positive site that we are looking to acquire lease. That's about a 10-minute walk away from the site. So particularly for staff, we think that will really increase the options we've got around that. And finally, at the Alexandra site, we think we've got options around putting some temporary car parking in around there. So at board previously, we've had a look at the land and how we use it and what it's been used for, and some of the deals that we've been in. But I think that's going to come to fruition as well. So potentially, we are in a much better place on all 3 sites, which was a key part of the 10-point plan and the hygiene factors. It feels like after quite a bit of work and probably slightly too long, we are really starting to make some progress on that.
Yeah, I know, Stephen, the enormous efforts you, Emma, and others have put on behind the scenes to get this over the line. But we are acutely aware as a trust as to the unacceptable delays for members of staff at the end of a busy shift, getting out of the car park, the damage that's been caused to cars because the car park is too tight. But so thank you for your forbearance. And Simon?
And another bit of good news, and Emma's ears will be burning red hot at the moment. We now have an appropriate voodoo facility at the Royal Hospital. This has taken a little while. It's been a little bit frustrating, but I know Emma's worked very hard to make this happen, along with Ali's support. And I'd like to pay particular thanks to the 2 staff networks who are involved with this, our Embrace network and also our Faith and Spirituality network, who have pushed and pushed and pushed on this. But we now have a facility that I think is more appropriate for the needs of our Muslim staff.
That's super. Thank you, Simon. And do we have any questions for members of the public, Ronnie?
No, we haven't had any come through.
Okay, I'd really encourage members of the public who maybe are watching this live stream in the future to not hesitate to ask any question, because that's what we're here for. We're a public sector service organisation. We're here to serve our citizens. Okay, ladies and gentlemen, I'll draw the meeting to a close. Suggest we meet in 10 minutes, a little bit earlier for the confidential board, so I can save the executives some time. So see you in 10 minutes at 2:15. Thank you very much. Take care.